Hello, this is Dr. Dan Guerra from VerEvMed Studios in the Pacific Northwest. Today we're going to do part 2 of a lecture series I'm doing on opioids. The last lecture, which I submitted yesterday for YouTube and uploaded, had to do with a frank discussion of opioid metabolism and biochemistry at the endogenous opioid level. We spent a lot of time talking about pain reception, also known as nociception. We talked about descending and ascending neural transmission. We did a lot of detail about the individual circuits that are involved in pain thresholds and how endogenous opioids, and even a little bit of discussion how exogenous opioids control or dampen the pain signal. So part 2 is going to be more on the actual biochemistry of opioid receptor and how it responds not just to endogenous, but to exogenous opioids. That'll be about the first third or so of this lecture. And then the rest of it's going to be on the opioid problem. And we're going to try to talk about generalizations associated with what's going on with the opioid epidemic. We're also going to talk a little bit about the pharmacokinetics of morphine to give you an idea of how that drug is metabolized in the human body. So let's get started. All right, so that was part 1. Now we're going to do part 2. So here we are. There we are. All right, opioid receptors and addiction. Let me get rid of that. Again, that's me, Dr. Dan Guerra. This is our company, VerEvMed. That's our email address to contact us directly through the website. There's our website. Here's the Facebook page where all of these YouTube lectures are placed. And there's my individual email address, and you can contact me, and I usually respond within 24 hours when you want to talk about any of the lectures that you've watched, or indeed if you want to talk about interacting with us at VerEvMed. Okay, we're a private-owned company, and we very much would like to have clients who might be interested in knowing more about basic science published in the peer-reviewed literature. That's what we do. We discuss that with our clients at the level that most is accommodating for those clients. All right, so again, it's a free lecture. It's going to be on opioid receptors and addiction. Let's get going. First of all, I want to do some summary from last time, in case you didn't watch the first one or you're not going to watch the first one. And this basically still comes from this 2016 paper by Stein in the Review of Medicine. So what can we say about opioid receptor-induced expression? Okay. Expression, axonal transport, signaling, and accessibility of the opioid receptor on the dorsal root ganglia depends on receptor type and the duration of injury. So remember that the expression of the receptor is modified and is sensitive to the pain threshold itself, the pain signaling, and that is in conjunction with the production of the endogenous opioid, which of course is the ligand for the receptor. So overall, the enhanced expression of the receptor will enhance analgesia. Okay, now why is that? Because the receptor is going to bind to the endogenous opioid or indeed to the exogenous. And when you have more receptors, you get more of a dampening of the pain response. It's also linked to an anti-inflammatory response because of the secretion of ultimately cortisol, which decreases the inflammatory response because the same proteins that are synthesized with the endogenous opioids are also those that control glucocorticoids and corticosteroids, which of course the corticosteroids are anti-inflammatory steroids. And that's why I say here consider the POMC propeptide with ACTH and beta endorphin being two protein products from that POMC propeptide. So if you don't know what I'm talking about there, go back and watch the first one. Basically, it's a polyprotein, and it's proteolytically degraded to such a point that you get individual polypeptides. One of them is ACTH, which is the adrenocorticoid protein that induces finally the synthesis of cortisol. And then, of course, beta endorphin is an endogenous opioid. So indeed, tissue or nerve injury is required to fully obtain peripheral opioid effects, while the local application of opioids along uninjured nerves or in normal tissue doesn't really reliably generate analgesia. That's because this system is tightly regulated by feedback inhibition and by proactive synthesis and splicing of individual receptors to accommodate the introduction and the increase of receptors upon severity of tissue injury. So an exogenous opioid application does not parlay correctly into those regulatory systems. That's one of the problems with the opioid epidemic, as we'll see. The association between receptor expression and the endo-opioids is concerted and regulated, while exogenous opioid administration completely overwhelms that tight cellular control mechanism. And again, that's the main problem with exogenous opioids, is they are not controlled by like the endogenous system is, and it's very easy then to get into potential for addiction or overdose. Okay, now what about receptor trafficking? We talked about again this last time. Axonal transport, on that afferent neuron, is stimulated by cytokines and nerve growth factor. And so you get that within inflamed tissue. And of course, that has to do with a frank injury, right? So the upregulation of opioid binding sites is due to an increase in the number of neurons expressing the receptor. So you get a proliferation of the neurons themselves, and you also get the number of receptors per neuron. Okay, so more of the receptors are synthesized, more expression, more transcription, more translation, more post-translational modification, and ultimately targeting of these receptors to the plasma membrane where they work, right? You don't see a change in receptor affinity. Why would that be? You'd need a mutation. You would need you would need a change in the splicing such that you were modifying the binding of the ligand. And that doesn't seem to be the case here, which isn't really surprising when you think about it. So the pre-treatment of cultured DRG neurons with pro-inflammatory chemokines resulted in internalization and functional inhibition of mu receptors. So take a look at that. When you get pro-inflammation with chemokines, which are a specific kind of lymphokine, which basically induces a signaling mechanism that promotes cellular trafficking so that you get an inflammatory response. When all that is happening, what also happens is that you get an internalization and therefore a functional inhibition of opioid signaling. So that means that after a while, inflammation shuts that down, okay? So that's probably another feedback loop. And that's why analgesia and actual opioid metabolism are not tightly linked when you use exogenous opioids, because in fact, they go their separate ways when you're using endogenous opioid signaling and trafficking. So what about endogenous opioids? Of course, they're peptides. Endogenous opioid receptor ligands are derived from the precursors. I already told you the POMC, which is pro-opioid melanocortin. That encodes a beta endorphin. Then you have proenkephalin, which encodes the metenkephalin and leuenkephalin. And then you have prodynorphin, which encodes the dynorphins. So there are three classes of endogenous opioids, right? So those are all peptides, and they contain a common tyrosine, glycine, phenylalanine, either met or leu, right? And that is where the actual binding is believed to occur. So that's known as the opioid motif, okay, on that peptide. Now, opioid receptor-mediated responses and dynamics. Let's get into this. Beta endorphin, the most common endogenous opioid, and the enkephalins are anti-nociceptive agents, right? So they're going to dampen the pain signaling. Anti-nociception means to decrease the pain. Of course, and they act at mu delta opioid receptors most commonly. There's also a kappa receptor, and there's actually one more. But the mu and delta are the major ones, that are major players in analgesia, right? The dynorphins can elicit both a pro and an anti-nociceptive effect, because they bind not only to the kappa opioid receptor, they also bind to NMDA receptors, right? So that's a totally different bipartisan effect, if you will, for the dynorphins. That's why they're called dynorphins, because they have diverse or dynamic or two-dimensional roles, right? They bind to an NMDA receptor as well as to a kappa opioid receptor, or KO. Okay, so they have different functions. We don't really know much about them. We only know that they've only been discovered relatively recently. We don't really know what they're doing. They don't seem to be particularly potent for analgesia, but we don't know if they're not modifying the other two receptors in some other way yet. So the opioid peptides and receptors are expressed throughout the central and peripheral nervous system. You also see them in the neuroendocrine tissues, as we talked about last time, and of course in the immune cells, which we also talked about. So you get a lot of opioid metabolism throughout the body, particularly when you think about trafficking of all of the lymphocytes and leukocytes. So extracellular opioid peptides are susceptible. What goes on here? This is a pharmacodynamic discussion here. To rapid enzymatic inactivation by a protein called aminopeptidase N and by a neutral endopeptidase. Those are called by the nickname enkephalinases. Both are expressed in the central nervous system, peripheral nerves, and indeed in the leukocytes, right? All right, in the immune cells. So that means rapid turnover, rapid breakdown. So here's the modulation, basically, that again, these are slides that we looked at a couple of times before. These come from a textbook called Pathophysiology, which I actually contributed to in one of the last editions of it. Not this particular chapter, though. So you have the PAG. That's where endorphins are generated. You also have 5-HT, serotonin. You have the rostral pons. Okay, this is in the CNS up here, right? The periaqueductal gray and the rostral pons. That makes norepinephrine. Goes to the Rafe nucleus. And then you get this descending central inhibition of this afferent neuron nociception. That's what we imagine is happening here. This is going down that, remember that, spinothalamic tract, right? Okay. So more on modulation. Opioids have different effects depending on the types of receptors they activate. The four types are mu, kappa, sigma, which I haven't talked much about, and delta. The mu is in the brain, the kappa is in the spinal cord, and they do have analgesic activities. There's a theory called the gate control theory that's out there, and it gets modified a lot because publications on it are frequent. What it says is that impulses carried by large myelinated cutaneous fibers, which we discussed last time, which are the A betas, could close the gate on nociceptor impulses. So those are pain signals then that would be blocked in the spinal cord and not allowed to progress to the brain at all. Okay? So that's a gate control. That means shutting down that pain response to the brain means also decreasing the emotional response and the need for the brain to function at a level when there's such severe pain that it may shut down, right? So there's a dampening, and this is called the gate control, of the actual pain reflex, if you want to call it that, way down there at the spinal cord. So you don't get the full, constant, high-level pain, because that would probably shut down the central nervous system because of overall stress to the system. So we also have a stimulation of large touch neurons, which actually also inhibit the transmission of the nociceptor impulses. That's why when you get say a bruise or you get a fracture and you rub that part of the body, it feels better. What you're doing there is carrying out some localized anti-nociception, right? And all of that then feeds into the spinothalamic tract and whether or not you get a strong signal into the central nervous system, particularly all the way up into the PAG. So rubbing, pressing, or shaking the painful area, as we all know, reduces pain. That's how that works. All right, take a look then, again, at another diagram, similar to the ones I looked at last time. So, you've got some kind of pain here showing you a nociceptive information in the periphery. You've got primary sensory neurons here. You've got ones that generate excitatory amino acids. You've got ones that generate the calcitonin gene-related peptide, substance P, think about it for pain, galanin and neuropeptide Y, all being generated down there in the periphery. You've got then this ascending pathway going up for pain sensation to the central nervous system, to the brain, for example, to the periaqueductal gray. And then you have the descending pathway, which of course is sending down the anti-nociception, such things as serotonin, such things as noradrenaline. Okay, now these are doing other things besides just pain control, but that's a basic phenomenon that goes on. You have an ascending arch and a descending arch. So nociception is transmitted from the periphery to the spinal dorsal horn by primary sensory neurons. We all have known that and seen that. I think we're all aware of it now. At that spinal level, the neurons transmit nociception to second-order neurons, and those are your ascending pathways, through the release of neurotransmitters like the ones I just mentioned, the excitatory amino acids, glutamate, etc. You see there. So then in the CNS, the nociception percept is the pain itself, right? Prefrontal cortex is involved and the entire limbic system involved. So you get an emotional response, which is working coherently then with executive function. Now, the transmission of nociception at the spinal level is modulated, this is just your standard understanding of what's going on here, by inhibitory interneurons through the release of opioid peptides and GABA. Remember, that's going to diminish that whole response there, right, because of the effect of the polarization of the membrane. It's going to be inhibitory neurotransmission, GABA, that's what it does. And also by the supraspinal descending neurons themselves. These are all called the descending pathway, which we went over. And that's through the release of serotonin and noradrenaline, as you see in the diagram there. By the way, I got that diagram from that particular book, Gene Therapy for Chronic Pain Management, as you see, published in February 2013. So the descending pathways inhibit or enhance nociceptive transmission from the spinal cord depending on the receptors and the ligand and the concentration. Highly regulated, not like exogenous opioids. So what about the alteration and perception of integration of pain? Okay, so altering the perception and integration of pain. Okay, this is now a topic we need to look at because now we're starting to move into what happens with exogenous opioids. When you're superimposing them on this really well-designed pain perception and analgesic phenomenon, right, which involves not just endogenous opioids, but all these other neurotransmitters. Right? All right. Opioids work at specific receptor sites located throughout the body, but are highly concentrated in the brain. We know that. The opioid analgesics have similar mechanisms of action, but vary widely in potency. So the opioid analgesics, the exogenous ones, they have side effects. They cause nausea, vomiting, respiratory depression, which can kill you with an overdose. And they cause apparently severe constipation for people who take morphine, who've known this now probably for thousands of years. Tolerance, you also get tolerance with analgesic opioids. And so that means there's a need for increased dose to achieve the same analgesic effect. That is, again, at the receptor level. There's also a physical dependence because of the withdrawal symptoms, and then withdrawal is so severe that people become physically dependent and then emotionally dependent, so they take the drug and the withdrawal symptoms go away, right? And that's how it works. It's stopped abruptly. And then, of course, finally, you get addiction, frank addiction. That's not an expected response to opioid therapy. It's a behavioral patterning of craving and indeed, finally, a preoccupation with obtaining the drug. That's because you're affecting a totally different pathway. Now, you may not look at it this way, but analgesia by itself doesn't need to be tapping into their reward pathway. The reward pathway is what's tapped into when you naturally feel good about doing something. That's a dopaminergic system, right? We haven't talked about the dopaminergic system all this last hour and now into this hour. Now we're going to look at this. So once you turn on or you basically pirate or enslave the reward system with opiates, that's when you run the problem of addiction and hedonia and ultimately anti-hedonia and ultimately overdose after addiction and all of the cause of death. Okay. So paper here talks about neuroplastic pain transmission. So what do we mean by that? Let's go into this totally different topic. It's really important. When peripheral tissue is damaged, such as if you are using a hammer and let's say you're building something like a chicken hut, chicken house for your chickens, and you bang that hammer on your thumb, right? That kind of damage. There are primary afferent neurons, and they are sensitized and or activated by various kinds of stimuli. The mechanical one I just told you about. There can also be a thermal, that's high temperature, like heat, like a fire. And of course, chemical stimuli. The chemical stimuli is all over the map. Simple protons, that is acid-base changes. Prostanoids, which come, of course, from the oxygenation of fatty acids, right? Think about leukotrienes, think about prostaglandins, think about thromboxanes, for example. Bradykinin, cytokines can also do this, of course, the pro-inflammatory ones that also generate heat and also edema and also generate pain, local pain. All that leads to an opening of cation channels in the neuronal membrane. One of them we talked about before, that was the TRPV1. Okay. Now, what commences from that pain stimulus through these cationic channels because of the stimuli, you get inward currents of sodium and calcium ions into the peripheral nociceptor terminal. If this depolarizing current is sufficient to activate, so you need a large enough signal, a voltage-gated sodium channel, they'll open, and they'll further depolarize the membrane, and that's going to initiate enough of an action potential that are then going to be conducted along the sensory axon all the way to the dorsal horn of the spinal cord. So you need to have a sufficient amount of that action potential. That, you know that. Very low level pain, some people don't detect it at all, like a pen prick, say, or I get a lot of these wood sections into my fingers because I chop a lot of wood, right? I get splinters, I mean by that. And splinters, I don't even know they're there, except maybe after I take a shower, I say, oh, look at all the splinters I had in my finger. Maybe then I feel them if I press my finger down, right? But you just don't detect them because it's not enough to generate that action potential. Okay. So the central terminals of the nociceptors contain those excitatory transmitters, and those of your standard glutamate, and in this particular case, substance P. These activate the postsynaptic NMDA receptors, as we talked about, the neurokinin pathways, and lots of other receptors. Repeated nociceptor stimulation will sensitize both the peripheral and central neurons, and that's going to be an activity-dependent plasticity, or as it's called colloquially, wind-up. That is, you get the pain stimulus, and then you get this repeated stimulation. That really hurt. I hit my thumb with a 5-pound ball-peen hammer. Wow, does that hurt, right? I'm sure many of us have felt that kind of pain. And it takes a little while before the real pain gets in. But when you get it, you know it, right? Of course. Right? So that's the wind-up. So later, sensitization can be sustained by changes in the expression of genes. So you're actually now getting changes in neuropeptide expression, transmitters, receptors, ion channel proteins, signaling molecules within the nociceptors, spinal neurons, and in fact even glial cells in the brain. Okay, so this is long-term changes of expression of all those genes. And there's also epigenetic modifications, which we're just now starting to investigate. So in addition, physical rearrangement of neuronal circuits by apoptosis, something we talked about quite a bit in VerEvMed lectures, nerve growth and sprouting, the arborization story we talked about, for example, with tetrahydrocannabinol and even a little bit with ethanol. When that occurs in the peripheral and central nervous system, those are changes then that are going to result in overall neural transmission, pain, nociception, as well as analgesia. Both induction and maintenance of central sensitization are therefore considered critically dependent on the peripheral drive by nociceptors, indicating that therapeutic interventions targeting such neurons may be particularly effective even in chronic pain syndromes. So this is basically why Big Pharma is interested in finding alternatives to the analgesics such as opioids, but why analgesics such as opioids are still used, because they work. They work really well, and we know how they work, right? So they are very excellent analgesics. Problem is, as we talked about, moving from dependency to addiction. They have their own special hell that they bring with them. All right. Now, I want to remind you what's going on with the opioid receptor. Think about at the level of G proteins. G proteins dissociate into the G alpha and G beta gamma subunits, and they can inhibit adenylate cyclase. Okay, this is here where they're going to decrease the amount of cyclic AMP, and they're going to decrease the conductance. Okay, the conductance of these voltage-gated channels, particularly calcium influx and the open rectifying or GERK potassium channels. In addition, phospholipase C and phosphokinase, or that is protein kinase C pathways, are also further activated, modifying the receptor itself. And all of that is used to modulate calcium channel activity in the plasma membrane. That's what's showing you here once opioids bind. Now, opioid receptor desensitization, that's all sensitization, occurs after long-term stimulation by ligand binding, right? Of course, there's always feedback. And then that trafficking is activated by G protein coupled receptor kinase, or the GERK kinase. So after an arrestin protein binds, you see here, the receptor is in a desensitized state already because this terminal of the protein, here's your 7-membrane spanning region, there is your extracytoplasmic part of the protein, functional domain and structural domain of the protein. Here is your cytoplasmic structural function domain of the protein. Once it binds with GERK and arrestin, what happens to it is that it not only is it desensitized, it starts to go through an internalization process, which involves clathrin-coated endosomic dependent pathways. In other words, they're recycled if there's not complete degradation, or in fact, they are sent off to the phagolysosome and degraded. Okay, so the more the opioid receptor gets stimulated, over stimulation, the more it can become desensitized. And when that happens, this is how you get to have a higher dependency, because less and less of the opioid receptors that were originally expressed and spanning that membrane at that neuron, ready to receive that nociceptive response and turn on its analgesic properties, it becomes desensitized because of overstimulation. The overstimulation, such as with analgesic opioids, then can ultimately lead to the complete degradation of the receptor, which now means a higher dose of the drug would be necessary to procure the same sensitization and finally, of course, the analgesic properties or anti-nociception. You see. All right. Now, we saw this slide before. It comes from that Stein paper. I keep on using that Stein paper. I really like it. We talked about the fact that you have all kinds of ways of receptors binding to their ligand, such as the interleukin receptor, such as the CRF binding to its receptor. And when that happens, it generates the endogenous opioid metabolism. It causes those opioids to be synthesized, okay? So when that happens, and you're down here, let's just read right off here. Endogenous nociceptive mechanisms within the peripheral injured tissue is what you're looking at here. The opioid peptide containing circulating leukocytes, which are these here, okay, that are brought there because of extravasation and adhesion molecules, for example, in the extracytoplasmic space. And that's induced by chemotaxis, by the chemokines that we talked about a few slides back. Subsequently, those leukocytes are stimulated by stress, or basically releasing agents to secrete opioid peptides. CRF, interleukin-1, norepinephrine are released from post-ganglionic sympathetic neurons. That's what this is here. And they elicit then the opioid release by activating the respective receptors on those leukocytes. Okay, so this is how combining the inflammatory response, the surveillance inflammatory response for pain induction, with the endogenous opioid signaling to cause analgesia. So the exogenous opioids will also bind to the receptors and carry this out. Now notice there's none of this regulation with the exogenous opioids. They just bind directly to receptor, right? So when they bind, or when the endogenous opioid peptides bind to the receptors, they are synthesized in the dorsal root ganglia and transported along intra-axonal microtubules to the peripheral and central terminals of the sensory neurons, okay? So that's this whole process that we've been talking about. Now, the subsequent inhibition of the calcium channels and also the TRPV1 and of substance P release results in overall anti-nociceptive effect. It's exactly what we talked about now 2 or 3 times. I want you to see, though, how the exogenous opioids come in and basically pirate the whole regulatory system. They're still modifying that receptor-mediated expression, partially because of that overstimulation causing desensitization, and also still a stimulation of receptors early on, right? A stimulation of the expression of the receptors. So the exogenous opioids are working on half of the regulatory component, but not on the part that causes good feedback control, because the pharmacodynamics of the exogenous opioids is nowhere near the pharmacodynamics of the endogenous peptide, so-called endo-opiates. Okay, that's the big key here. The exogenous drug, just like when we talked about the cannabinoids are nothing like anandamide, the naturally occurring compound that binds to the cannabinoid receptor. So this is what always happens with drugs. All right, so let's talk about opioid drug dynamics then. Opioid receptor expression is poised for peripheral, by that I mean topical, intra-articular, neuroaxial, and systemic, such as intravenous, oral, subcutaneous, sublingual, and transdermal pain. Okay, so let me say that again. Opioid receptor expression is poised for peripheral and systemic pain. Okay, and when that happens, okay, you have this normal regulation. Now, what about when you take exogenous opioids? Morphine, codeine, even methadone, fentanyl, they're all mu opioid receptor agonists, right? That means they're going to bind to that mu opioid receptor and they're going to transduce the same signal that the endogenous opioid does. That's what it means by an agonist. So drug selection, these kind of drugs, is based on the pharmacokinetic considerations. That's what we talk about in pharmacokinetics: the route of administration, the absorption, the distribution, the desired onset of duration, the extended release formulations, metabolism, and ultimately excretion, right? All of that's part of the pharmacokinetic Bible, right? Do you take it orally? Do you take it subcutaneously? Do you take it intravenously? Do you take it as a patch, sublingually? All these different possible routes of administrations, all going to have a different effect on the kinetics. That is the ultimate degradation or sequestration of the exogenous drug. And that alteration is going to generate potential side effects. All right. Now, you also have mixed agonist-antagonist. That's like buprenorphine or butorphanol or now bufrine or pentazocine. Okay, those kinds of drugs are called mixed function agonist-antagonists on the receptor. They can act as agonists at low doses, so they act like an analgesic at low doses, but they can act as an antagonist at the same or different receptor type at higher doses. So if they're acting as antagonists, they're not going to decrease pain, they're going to actually enhance pain, see? Or at least shut down the analgesic response. Mixed agonists exhibiting ceiling effects for analgesia. That means ultimately analgesia reaches a point and there's no more you get. And they can elicit an acute withdrawal syndrome, nevertheless, when administered together with a pure agonist. Okay, so this is the problem when people have chronic pain. They're often given a mixed function antagonist-agonist with a pure agonist. And when you put those in combinations, you can get severe withdrawal and you can have a ceiling on analgesia where you still get pain and yet you still get withdrawal. Okay, it's a terrible situation to be in for people that are taking these drugs, right? It's quite a roulette wheel. It's like going to Las Vegas, right? Where you're very likely in the long run going to lose by continuing chronic use of these exogenous opioids. Yeah. So the mu receptor mediates not only this analgesic effect, but respiratory depression, severe deep sedation, and of course it affects, as we talked about, the reward pathway, which gives you euphoria. Also, it causes nausea, urinary retention, biliary spasm, and ultimately also constipation. Okay? The kappa receptors mediate dysphoria, aversive, sedative, and diuretic effects. So quite different, but all negative, basically. And the delta receptors can mediate reward, again, respiratory depression. Again, those are two bad things. And of course, also the delta receptors have the added terrible negative effect of generating convulsion. Okay, so really got to be careful about what drugs are being administered. And a lot of the exogenous opioids will bind to multiple receptor subtypes. All right, so now, if that's not also interesting, you should know that opioid receptors are also, because they work in immune systems, are also known to modulate antiviral effects. Okay, so opioid receptors have been shown to modulate virus, cellular growth, inflammatory response, and even wound healing. Okay, so these are all extracurricular effects of exogenous opioids. So viral key factors can bind to these exogenous opioids on viral receptors. They can interact with proteins. They can interact with the promoters on genes. They can impact viral infections such as HIV, HCV. Okay, they can also affect and modulate epigenetic mechanisms, showing here methylation, acetylation, either of the DNA or of the histones. Right? Yep. That is going to alter messenger RNA levels, and it's also going to cause changes in splicing. Ultimately, all of that can affect viral infection, for example, like HIV, because you're affecting then the reproduction of that virus. Third thing is a direct effect on the immune system, as we know, because of the leukocyte phenomenon, modulates host immune responses, directly and or indirectly can affect then viral pathogenesis, because you're affecting, right, off target the immune response. And ultimately, of course, if you get viral infection in the CNS, you have opioid receptors there that can either positively or negatively affect the pathogenesis of the virus, depending on this desensitization, oversensitization, and of course the ultimate destruction of the opioid receptor because of overstimulation, because of exogenous opioid. Okay, so that is all something to keep in mind. I got that from Frontiers in Microbiology, a paper published a little over a year ago, about a year and a half ago. Now, here's another paper from the British Journal of Cancer, seen here, published. This is about 3 years ago. Not quite. Well, yeah, 3 years ago plus. There's your opioid, lovely old morphine. You know, it has central effects on the brain. You know, it has peripheral effects, for example, on leukocytes and lymphocytes, right? What is the MOR? That's the mu opioid receptor. And TLR4, we talked about quite a bit. We discussed THC and ethanol, but TLR4 is basically found on the innate immune cells, and it is involved in responding to exogenous antigens. Okay, so this is going to be involved heavily into the immune response. Yeah, okay, so opioids have an effect there, as we've been saying. All right, opioids have an immunosuppressive effect by activating the periaqueductal gray. We talked about that last time, which activates the sympathetic nervous system. That SNS innervates lymphoid organs such as the spleen, and this activation induces the release of biologic amines, which suppress splenic lymphocyte proliferation and actually suppresses the natural killer cells. So this can be anti-inflammatory, but also it can be immunosuppressive. So opioids in combination with having viral infection is not at all a good thing, right? Because you're suppressing then the body's natural ability to fight off virus. In fact, I would probably argue it has a similar effect on bacterial and fungal infections because it's an innate immune response after all. Okay, that's basically what we're talking about here. That's why I brought this up. I wanted to give you an idea of how opioids, as exogenous opioids, as in drugs, have a completely off-label effect on various components of the body, ones you would not imagine, simply because of the intoxicating effects of opioids, or the euphoria effects, or the analgesic effects, the frank analgesic effects. All this different effect on the immune system. All right. So, altering the perception and integration of pain. Here are your common opioids. Here's the approximate equal analgesic dose, either via oral or parenteral. Oral, you have to take more of, right? There's morphine, there's codeine, there's OxyContin. Much more of that is needed than morphine or codeine. There's hydrocodone, hydromorphone. There's Demerol, that used to be a synthetic opioid that was used years ago. I know in the hospitals in Buffalo, New York, I knew somebody that was involved in all that. Demerol used to be a major synthetic opioid that was used for those kinds of systems in hospital settings. This was like talking 30, 40 years ago. I think it's highly addictive. It's not used as much anymore. And there's methadone. So you can see that the oral administration is going to be different than the parenteral administration. We all know that, but this is just a table showing there's quite a bit of difference, right? Several fold difference in how much is taken in. All right. Now let's go to this paper, and also in the Review of Medicine, published just very recently. In fact, it just came out January of this year. This is only March 13th, 2018. And this paper is not talking about opioid receptors, but opioid overdose. I'm going to complete our talk today using this paper and a few other papers, which you'll see references for. Okay, what are we saying here? Opioids induce a respiratory depression by activating the mu receptor on the brainstem neurons that control breathing. The overdose risks increase with higher daily doses, so it will kill you. Right, that's what happens with heroin addicts that keep on taking more and more, and ultimately they're found dead. The use of long-acting opioids such as methadone and oxycodone has also been associated with increased risk of overdose. The combination of opioids with alcohol or with sedative hypnotics such as benzodiazepines and even antihistamines all increase the risk of overdose. Okay. What about the clinical indications as predictive of opioid overdose risk? Okay, this is more now for the clinician. First, if there's a history of prior overdose, that increases the future overdose risk. Standard stuff, you probably see this also in the DSM-5, right? Psychologists all know this. Second, a history of addiction to any substance, but particularly alcohol, benzodiazepines, or opioids, means that you're very likely could get addicted to opioids, right? That's because alcohol has very similar effects. Now, I would add in there, from my research anyways, the potential also for cannabinoids to also enhance the addictive properties of subsequent opioid utilization, overuse, or that is abuse. Third, health problems associated with respiratory compromise and a concurrent prescription of any medication having respiratory depressing effects, such as the benzodiazepines, which are still sometimes administered and by psychologists and psychiatrists, or sedative hypnotics, which are again used in the psychology industry, they can impose an increased risk for overdose. Central sleep apnea itself is a separate risk factor for opioid overdose. A lot of people suffer from that have no other drug use. Renal or hepatic dysfunction, okay, also increases the risk for overdose because of clearance of many of the opioid drugs is impaired. Okay, that makes perfect sense. If you can't detox the drug, remember, going back to the pharmacokinetics, right? You can't detox it, you can't eliminate it. You can't get rid of it via the kidney, right? So it stays in circulation, it stays in the blood, binds back to its receptor, whatnot. All of that, any kind of problem with kidneys or liver, any kind of, for example, obesity-associated metabolic disorders. Right. You see what I'm talking about here, like things like diabetes. Of course, other things that can affect the risk factors are prior suicidal thoughts, going back to psychology, psychiatry. Attempts or a diagnosis of major depressive disorder, also markers for elevated risk of a drug overdose, which can kill. The urine test ensures no presence of other drugs that may magnify opioid effects on respiration. So the urine test still stands as something that's very useful when opioids are going to be administered. All right. So the identification of those risks does not automatically rule out opioids. So sometimes they're still considered the right thing to do for some kinds of chronic pain because they are very effective at pain management. But consider these issues as a clinician or as a patient that might be considering taking opioids because of chronic pain. First of all, there's a much greater patient and family education about overdose risks that needs to be done. The use of an opioid treatment contract is being considered, where a patient will actually get into a legal agreement or contract with his physician or her physician so that they agree to only take the correct dosage and only to be on the opioid for a limited period of time. There's also a greater caution for prescribing high opioid doses in general, or anything that's a long-acting opioid. Maybe we can start pulling back those kinds of things. Low doses, that is, low compounding levels of the opioids, and less in each prescription. Okay, and getting rid of the longer-acting opioids, which can, of course, confound the receptors and lead ultimately also to overdose. We also may be we may need more frequent clinical follow-up and potentially a prescription for an instruction in the use of naloxone, which is an opioid antagonist that can reverse opioid-induced overdoses. Maybe there needs to be administered the same time the opioid is given as a prescription, an identical prescription handed out at the same time, so that you go to the pharmacy and get this also filled for naloxone, just in case you make the mistake, the patient makes the mistake of opioid over-administration and therefore overdose and potential for hazards such as death. So expanding access to naloxone is one of the things brought up in this 2018 Annual Review of Medicine. And they're saying it has been shown to significantly reduce opioid overdose fatality. That's something that if clinicians have not been considering, it might be something to consider. It's a recommendation that looks like came from that review article. Now, what about addiction itself? There's a misconception out there that, and by physicians, that pain protects against the development of addiction to opioid medications. That's not the case. People think, well, this is a prescription drug. I'm taking it for pain. When the pain goes away, I won't really want it anymore, so I won't get addicted. That's misconception. There's no literature out there in the scientific and the patent referee literature that says that that's the case. Okay, it's because the executive decision that goes on with thinking that your pain is reduced is something that no longer will function well with someone that is dependent on opioids on a daily basis. Let me continue. Patients suffering from acute or chronic pain can indeed potentially become addicted. This is actually the most common way they become addicted. Okay, so chronic pain can enhance the reinforcing effect of the opioid in a dose-dependent manner, just like it would be if it was purely for recreation. You get a tolerance, then you get a physical dependence. Again, think about the receptors being pulled out of the membrane. And that's common, and it's expected, and it is truly a consequence of repeated opioid exposure. Okay? In contrast to that, addiction to opioid medications occurs far more rarely and develops much more slowly. So a direct addiction does not happen right off the bat. So it's also a misconception to think that if a person takes OxyContin and then the prescription runs out, they automatically will be addicted then and there, and that's it. They become addicts, opiate addicts. It's not also supported in the literature. It's a slow progression, right? It starts off with people treating their pain and thinking they need more and liking to see the pain go away completely. That's part of it. It's a repetitive operant conditioning, if you want to call it something. Then you build up a tolerance to it. You need more and more. You get a physical dependence. It's turning on also at this point maybe reward pathways. Ultimately, then you can become truly addicted, and that can, of course, lead to overdose and death. So it's a process. So the iatrogenic addiction varies substantially. When you look at the data, iatrogenic means, that is the administration of it, right, from the medical profession. And the amount of addiction you really see is all the way down less than 1% to almost a third of all patients prescribed. So why this huge variation? It's probably because there's confusion about aberrant behavior or withdrawal symptoms or dependence. And all of those can be confused with true addiction diagnosis. And that's because a lot of your clinicians don't have a real good understanding of the other symptoms involved in true addiction. In fact, diagnosed addiction seems to be pretty stable, even during the midst of this opioid epidemic, at about 8% of cases. Now, it doesn't mean there isn't more in certain geographical locations or in certain subclasses, age distribution, for example, racial distribution. There could be quite a variation of addiction amongst different populations according to gender and age and race. These are also being looked at. The data is also being looked at. But in general, frank diagnosed addiction only seems to be about 8% of all people who have been given pharmaceutical-grade opioid. This is not, of course, the people that are taking heroin or morphine for recreational purposes. That's a different group. Now, misuse and addiction-related aberrant behaviors have been reported much higher. Okay, but you know that's leading to, that is a bit of a slippery slope. Misuse, that is taking the drug out of sequence, taking more than the dose that was required for the day, taking more because, it hurts so bad, I need to really knock down this pain because I have to get on a plane and do something overseas and I have to get back to work in my office, or I'm a ditch digger, or I'm a woodcutter and this pain is killing me, so I just want to take more of these opioids. All those excuses ultimately leads to that dependence, right? And requirement to have more, right? That is really a dangerous and slippery slope. And there's no doubt about it. It's a small percent, but growing percentage of individuals addicted to prescription opioids transition to heroin. Why do they do that? Because it's cheaper than trying to get the actual pharmaceutical. And of course, in some places, very tragically, it's more available. Okay, it's more available. Now, heroin is a really strong analgesic. It's a really strong reward pathway pirate of a drug. Okay, because it's an acetylated form of morphine. It moves much quicker through the body. And once it's deacetylated, it acts just like morphine anyway, once it gets into the, for example, central nervous system. Okay. There are pleasurable effects of opioids then, and those are triggered by the reward pathway. And what that involves is dopamine release in the part of the brain called the nucleus accumbens. That results in a learned association. Remember I told you conditioning between the drug administration and the experience of pleasure. Not only do you get the analgesic effect, but apparently when you take these opiates, you start feeling high. And that pleasure reward system from the dopaminergic pathway, okay, from the nucleus accumbens and the substantia nigra, that all turns on the affect, which makes people feel good about taking the drug, even though the drug is supposed to be taken just for pain. Right? Some patients, the conditioning to the relief and withdrawal systems also makes it hard to discontinue. So if they start tapering the drug, your physician, your clinician says, okay, we're going to taper this drug off. People start getting withdrawal symptoms, which are very frank and real in opioids. And when that happens, they want to continue to take it because they don't like the withdrawal system. They would rather have an addiction than they go through the withdrawal. Very standard thing that happens to hardcore addicts. That's why they have to usually go into a clinic and completely dry out. It's very difficult for them to kick it on their own. So within the limbic system, the medial amygdala, the stria terminalis, and the medial hypothalamus, along with the periaqueductal gray, comprise all core elements of what's called the anger circuit. Now, if you ever wonder about why addicts sometimes get angry that they don't get their dose, I recently published on anger. So this is directly from a chapter I wrote in a book on anger and anxiety. So then I go on to say this circuit, this anger circuit, maps onto the reward pathway quite nicely and ultimately involves the catecholamine dopamine. Okay? So the anger circuitry and the reward circuitry co-inhabit the same regions of the brain, central nervous system. So it's not hard to understand how taking what was at the beginning just an analgesic, such as an exogenous opioid, leads then ultimately to some kind of dependence, and then ultimately aberrant behavior, more and more seeking of the drug, and ultimately to addiction because of the pirating of the reward system. But when that drug is satisfaction is not met, once full-blown addiction occurs, or maybe even before that, anger can erupt because the same circuitry is being altered, and they co-inhabit the same regions of the brain. That's something that I wanted to leave with you as well. So let's take a look at this reward pathway real briefly, and we're about done here. Okay, so here are the dopamine pathways, and what do they function as? Okay, here are your dopamine pathways. There's the nucleus accumbens, okay? There's the VTA, the ventral tegmental area. There's the Rafe nucleus. We've been talking all about these already just with the opioid system. There's the hippocampus, the substantia nigra, where catecholamines are secreted. There's your striatum, and there's, of course, your entire frontal cortex. The dopamine pathways are the blue arrows. See where they're functioning at. Give you reward and motivation. They give you pleasure, hedonia, euphoria. They help fine-tune motor function. They're also involved in such strange behaviors as compulsion and perseverance, okay? These are all positive feed-forward mechanisms, right? You feel good, you feel pleasured, you feel like you're satisfied, you feel abundantly good or high. You get sometimes an increase in motor function. You get also a compulsion to be continuing to do the same thing because of all this reward going on, and then you persevere with the system. These are all normal dopaminergic pathways, which are fine as long as they're not impacted by an exogenous drug. Right? Now look, that's also linked to the serotonin pathways. What are the functions of the serotonin pathway? Mood control, memory processing, the sleep function, and cognition. So you can see how dopaminergic pathways and serotonergic pathways, even though they are abundantly different in where they ultimately signal in the CNS, can all be modified, affected negatively by exogenous opioids, the analgesic effects notwithstanding. So again, here's the reward pathway, the dopaminergic pathway is the prefrontal cortex. The nucleus accumbens here is where you get motivation and goal-directed behavior. That's all a positive thing in the brain. Here's the ventral tegmental area I just talked about. That's where actually dopamine is synthesized. Remember, that's just a catecholamine. So the dopamine is a signaling agent in the brain. It's crucial to memory formation, helps the animals remember experiences, also humans experience, and increase in remembering experiences because of dopaminergic pathways. You get both positive and negative effects depending on how that memory is occurring. That's an operant conditioning effect. And the stamped-in memory gives the animals the motivation to repeat pleasurable experiences, and we're animals, and that indeed is where this is coming from in this limbic system. All of this can be pirated by the analgesia and ultimately to the drug, the opioid. So I just want to talk a little bit about morphine pharmacokinetics in case we forget that they're quite different from the pharmacokinetics of endogenous opioids. First of all, the mu opioid receptor doesn't care what binds to it as long as it's an agonist. It can be beta endorphin or an enkephalin, metenkephalin, for example, or it can be morphine. It's going to do all these things. It's going to desensitize all that pain system we talked about before, adenylate cyclase, the G protein couple, the GERK, the calcium channel, right? The arrestin, which is going to control ultimately the degradation of this receptor. Protein kinase C, protein kinase A is also affected. You also get endocytosis patterns occurring because of binding to the mu opioid receptor through phospholipase D2. Again, more arrestin activity, the clathrin, that's all the endosomal, lysosomal, phagolysosomal pathways. And then you get completely G protein independent signaling, and these involve kinase pathways and also more beta arrestin. So these ultimately are involved in other control of metabolic sequences within the cell that are completely off target from what the analgesic responses are. Okay? And that comes from Pharmacological Reviews, 2013. Now, also one more thing. Here's a basic rundown of morphine pharmacokinetics. I got this from a website SlideShare. You get absorption and distribution. It's variable orally, but normally we don't take morphine orally. But first pass metabolism, given as either IM or IV, much more common, intramuscular or IV. Widely distributed, there's morphine get in the liver, the spleen, the kidneys, etc. Enters the brain slowly. Readily crosses, however, the placental barrier. That's why you get fetal dependence and addiction. The metabolism, finally, in the liver by glucuronidation. You make a water-soluble metabolite. So morphine 6-glucuronide still has the analgesic properties. So this is now a pharmacokinetic product, but it's still analgesic. And especially when you get renal failure, you get more and more of the analgesic effect, prolonged analgesia. However, the morphine 3-glucuronide has no analgesia. In fact, it's neuroexcitatory, okay? Which, again, is a bit paradoxical. Excretion is via the urine. The half-life in the plasma is about 2 or 3 hours of morphine itself. Action can, however, last several more hours because of this degradation product lasting longer. However, within 24 hours, it's usually completely eliminated. The preparation can be down there to milligram level. IV much lower, of course. All right. So conclusions extracted from the annual review paper. Mild pain or withdrawal symptoms can trigger self-administration of the opioid. Repetition of drug exposures disrupts dopamine-modulated striatocortical pathways. That impairs the function of the prefrontal cortical regions necessary for self-regulation and control. Again, the reward pathway pirating I've been telling you about. Neuroadaptations occur that can lead to an escalation of opioid use, and the compulsive drug intake and impaired self-control that characterize addiction are all part and parcel here. Opioid addiction shows a long latency of expression. Adolescents and young adults are very sadly particularly at high risk because of enhanced neuroplasticity, or in fact with the older folks because of neurodegeneration and senescence of the brain. According to the DSM-5, addiction should be suspected when there is a pronounced craving for the drug by the patient, obsessive preoccupation with the drug, thinking about it all the time, and the inability to refrain from using it, even when it's no longer needed for analgesia, for example, and then ultimately an escalation of the drug seeking and taking. Right? That all leads up ultimately to that drug overdose, which no one wants. But the addiction itself is also hell. So the use of medication-assisted therapy, such as the anti-opioids, in managing opioid addiction among patients with co-occurring pain significantly can improve outcomes. Okay, so this is something we have to keep in mind. That remember that prescription of naloxone, for example. All right, so we're done now with discussing opioids. We had 2 chapters on it. This is the end of the second one. Thank you very much for paying attention to this VerEvMed now YouTube lecture. Ultimately, what I'm going to be doing is following up on some of this opioid epidemic stuff by looking at some of the more primary literature. We've been looking at reviews here, as you saw. We want to look at that primary literature ultimately because we want to see what's most current, what's going on with the epidemic. Certainly, there are things happening all the time. But I think you're going to see, again, a co-prescription of naloxone for people that are taking opioids. You're going to see a lot less opioids being prescribed to people with chronic pain, even endurant chronic pain, even sometimes severe, even neuropathic pain. Alternatives for opioids are being considered all the time, of course. Also, you're going to see less long-acting opioids, lower doses, etc. This opioid epidemic is a very serious problem. It's not going to go away easily or quietly or quickly. It's going to take a concerted effort from the research community, particularly from the medical community, also from social services, the psychology and the psychiatry communities, and most importantly, from regular people who are taking these drugs. They have to know these drugs are very dangerous, and before even taking them, they should think hard about that. If they are taking them, they should always have complete control over the use of that drug and be able to get way before ever becoming dependent on that drug so that they can get it out of their life completely. So thanks so much for listening to my lecture. I'm going to give you my normal sign off. Bye for now.